So I just wanted I'll go through this sort of relatively quickly. I'm happy to sort of answer questions kind of after, but really this is that last point around evidence. So this is something that really, I think, needs some discussion, and it's something that comes up a lot and keeps coming up a lot in the context of my interactions. There's what I would consider what's sort of often considered evidence-based practice, and then there's what's considered evidence-informed practice. And these things get used interchangeably, but they're not the same thing. Evidence-informed sort of means it's guided by evidence. Evidence-based means, the way that I think about it, that there's actually evaluation work done on that particular thing. And there's also other terms out there for this. Now, when you talk about evidence-informed practice, the idea is that you're integrating research, expertise, and experience, which is what this graph here is showing. But this sort of idea of how do we think about evidence and what do we use, I think is an important one. And so the way that we're approaching this is partially from not partially, sort of heavily informed by a scientific framework. Of course, acknowledging that there are other forms of evidence. But there's a couple of things that I just want to walk through really quickly in terms of how we think about evidence and what we need to do, basically to convince people. And the reason for this is partially that those who are already interested and committed to meditation and other contemplative practices are already sold. We don't have to convince them. Who we have to convince is the people that think that this is BS, or think that we're giving them some magic pill, or that think that this is garbage that we're throwing at them and that it's new age hocus pocus. So the way that I think we're going to do that is by acquiring really strong, solid, rigorous empirical evidence. So some things to consider when we're doing that is that the hypotheses or the things that we put out there need to be falsifiable. And this sort of goes way back to sort of, philosophy of science and its sort of heyday when this first came out. So we need a proposition. We need an idea that could be contradicted. So an example of a falsifiable proposition are all swans are white. If you see a black swan, you know it's false, right? A non-falsifiable proposition is all angels have wings, right? We have the instruments, we have the ability to measure the length and the possibility of wings, but unless we can capture an angel, we can't actually test it. So, people may say they've experienced or seen angels, but as scientists, unless we can actually somehow manage to capture that angel and measure the wings, we have no way of proving that proposition false. So that is an issue. The scientific methods that we have can't address that issue. Now, there's sort of, I'm gonna go through different types of evidence, and then I'm gonna sort of situate them within what we consider to be a pyramid. So, and I'm using an example here of the Mediterranean diet. So if you take the proposition that the Mediterranean diet is useful for preventing cancer, there's a number of different types of evidence. The first being personal experience or clinical expertise. So the example of that might be a physician you're talking to who says, among my patients, it seems that few on the Mediterranean diet have developed cancer. It's a really great starting point. It's interesting knowledge. It's a way of sort of going, maybe there's a link between the Mediterranean diet and preventing cancer, but it doesn't necessarily provide us with a particularly strong or robust set of evidence for reasons that I'll elaborate on. There's repeated observation. So over time, as you talk to GPs or you talk to clinicians or even talk to individuals, they may say patients to whom I've recommended this diet don't seem to develop cancer. So that's a slightly higher degree of evidence. They've seen it occur multiple times and there seems to be a link. The next thing would be what we call case control studies. So we can compare those who do versus do not eat the Mediterranean diet, whether or not they're likely to get cancer. Again, slightly stronger and more robust style of evidence. Then there's what we call cohort studies. So in this case, we say we take a group of individuals, say all born at the same time at the same place. So maybe we take a selection of people in their 40s, all living in Melbourne, and we look at the differences. We monitor them over time, and we look at the differences among those who do adhere to a Mediterranean diet versus those who don't, and then we look at the incidence rates of cancer. And then the final option, which is sort of the thing that we get the most robust and the best evidence from, is a randomized controlled trial. And this is where we randomize people. So we basically say there's an equal option of getting the Mediterranean diet or something else, and we can then measure the incidence of cancer. Now, these are considered to be placed in a pyramid. So we talk about the evidence pyramid. And the idea of this is that as we go from kind of clinical expertise or expert opinion all the way up to randomized controlled trials, that the quality or the robustness of that evidence is getting stronger. So as we're going from that sort of thing on the bottom to the thing on the top, we're more confidence that that evidence will, that we have will generalize And so the 3 points I have on the left, so it means that it will apply beyond a single individual or multiple individuals. We can start talking about recommendations for population. There's a greater ability for us to establish causality, meaning we know or we're confident that the thing that we're recommending drives the change that we observe. And the last point is that there's a lower risk of what we call confound. And I'll explain those 3 things really quickly. Apologies, I didn't talk about that. So the types of data on the top here in this pyramid are filtered data. So this means essentially you're now taking individual studies and you're collating them. There's some controversy as to whether or not that is actually the best form of evidence. The reason being that you introduce a lot of experimenter bias. The person who does the analysis may have a particular opinion, and that can get introduced. So there is a bit of debate as to whether that actually should be at the top of the pyramid. But the difference between a systematic review and a meta-analysis, is quantitative. So it means you take the raw data from all of the original studies and you lump it all together. So a study that's maybe had 30 people and a study that's had 100 people, in a systematic review, they may get treated equally. Mm-hmm. Whereas in a meta-analysis, the study that has 100 gets weighted more heavily because it has more people. So the idea in a meta-analysis is that better done, better controlled studies count more in your overall conclusion. Whereas that's not necessarily the case in a systematic review. So when we talk about generalizability, this is really, it has to do with how we sample our populations. So the goal is that if we're randomly sampling from the population, we want a representative sample. So when we get a representative sample, we're more confident that that sample actually reflects what's going on in the population. Now, the thing that's worth noting here is that the more people we can get, the better likelihood we have of that sample being representative, because that's just sort of by law of sort of us randomly picking people. You know, if the bigger the samples we can get, the more likely they are to be representative. So when you're looking at representative samples, you are much more confident that your conclusion will generalize, that it will reflect what's going on in the population. You know, I have a toy example over here. If you have a non-representative sample, so let's say you're looking only at a particular group of people who are particularly interested in diets, that doesn't necessarily tell you about the population as a whole. It only tells you about that select sample. And so there's limitations and challenges to that. And similarly, sort of when you have very small samples, the concern sort of is this may be ends of one. You know, one person had really amazing experiences with a particular practice or a particular process. It's very hard to say whether or not that will be true for the population as a whole. So that's the principle of generalizability. The idea of confounds, and this is particularly true when we think about those things lower on the pyramid, or if we're sort of even just monitoring people in the real world. So you take the example that I gave you of, you know, people who naturally are inclined towards the Mediterranean diet, or, you know, or things of that sort, versus those who are interested in just other, or, you know, kind of your generic Western diets. The problem or potential confound could be that if you look at those within the Mediterranean diet group and you think about how many of those people are physically active versus our comparison group, if there's a systematic difference such that there are more physically active people in the Mediterranean diet group versus the other diet or the comparison group, that could potentially be the thing that's causing the difference. Similarly, if you look at in the Mediterranean diet group, that you look at family history of cancer, there may be a lower incidence. So in other words, it may be that people that are drawn to the Mediterranean diet are already likely are less likely to get cancer in the first place for reasons that don't necessarily have to do only with the diet. So that becomes a problem then, because we then cannot conclude that it is the Mediterranean diet that is conferring the protective benefits or elements of the thing that we want to. So if it is these other things, without sort of randomizing people, we really can't conclusively say that we can recommend the Mediterranean diet as something that could prevent the incidence of cancer. The final thing then is sort of this idea of causality. So the idea sort of is when we randomize people to get things, we have to measure at multiple time points, and we have to rule out confounds. So I've got the example here of a person, you know, pushing dominoes. We have to rule out the possibility that there wasn't a gust of wind. You know, we have to know that it's the thing that we're doing. We are giving them something. We're randomizing people to get something or not. And then we can say that that's the thing that caused the thing that we observe. So if there's a decrease in depression or an increase in well-being, we know that it's because of the thing we randomize. It's the thing that we control. Now, the point that I would make about this is obviously there are some questions that are not amenable to this method, and that doesn't mean we don't look at them. We can't randomize people to be smokers or not. It's not ethical. We can't randomize people to be Christians or non-Christians. They wouldn't agree to it, presumably. We can't randomize people sort of to engage in meaningful, deep connections with the indigenous practice versus not. You know, I can't send a bunch of people to go and live in Kimberley and tell a bunch of people to stay here in Melbourne. You know, it'd make for a great experiment, but it wouldn't necessarily be ethical. So these are just, I think, some important considerations in terms of how we get our evidence. And the idea sort of here is sort of, you know, and how this might apply to us is sort of we're moving from this idea of personal experience and clinical expertise. It's a great starting point. It's a great way for us to sort of go, where might there be potential? So we can listen to clinical expertise. We can have discussions with people that meditate. It might give us a sense of where might there be the possibility for causality? Where might there be the possibility for what's going to happen? How do we actually, and the reality at the end of the day is that randomized controlled studies are extremely difficult to run. They're very time consuming and they're very expensive. So you don't want to do them unless you really know what you're looking at and you have a really specific question, because to do them takes years sometimes. So you start with all of these other types of evidence and you build towards that randomized controlled trial with the idea that I want to show that one specific thing, a particular type of meditation, causes a very specific outcome. And once you've done that, you then have really robust evidence that will hopefully be very compelling or convincing to a very broad group of people.